Awesome. All right, so let's get started. So thank you to Seattle Science Foundation and to the course directors for inviting me to give this talk. And this is going to be just a natural progression from what we talked about earlier today, which is the use of navigation, robotics, and talking a little bit about AR and VR in endoscopy and whether it's something that is helpful or not, so a friend or foe. So my name is Osama Kashlan. I'm the person that's going to be moderating this session. You're going to have three phenomenal surgeons who will talk about three different technologies that are helpful in their hands to help with getting through their cases, especially tougher cases like that scoliosis case that we saw earlier today. So what is the biggest problem in MIS surgery? And this is whether it's endoscopic or tubular, is if you're not familiar with it, you have decreased visualization of anatomy, which usually allows us to know where we are. So you're relying a lot on tactile feedback. You're relying on small pieces of visualization of the anatomy rather than the entire anatomy. And because of that, you're using a lot of X-ray shots. So really the challenge in MIS surgery, whether it's endoscopic or tubular, and more so in endoscopic because the area of visualization is smaller, is that you want to simultaneously know where you are in the AP and lateral planes and know where you are going with the least amount of radiation and in the least amount of time. If you could do that, then you've mastered minimally invasive surgery. So for all these three things here, really navigation helps. How does navigation help? It increases accuracy. We know that it does in pedicle screws. We know that it decreases radiation exposure to the OR staff because of the decreased number of X-ray shots that you have to take. And it also potentially allows you to have real-time tracking of where you are. So earlier when we were talking about what do you do when you get lost or when you're docking or when you're doing anything, navigation helps decrease the chances of you being lost and in general, in my opinion, makes your learning curve in endoscopy a lot faster. So to study this question, a couple of the sites from the Endoscopic Spine Research Group, we're looking at seeing if using navigation helps with increased accuracy, meaning does the number of passes during a transforaminal approach to get to the correct place, does that decrease with the use of navigation? And does the radiation exposure to the OR staff decrease? And this is just a quick pilot study from Michigan only, but we're going to be putting all our data together, and that'll be out hopefully within the next couple months. You could see here, just from a small number, the number of shots taken is decreased by half. The number of passes to get into the foramen correctly decreases also by half, and then the different radiation doses is also decreased. So this is interesting to see just in a one center, but when we put all our data together and all the different types of navigation, when we put all the data together, it's going to be great for us to see that. And that's really what today's lecture is about, is what the different types of navigation are out there and how it helps us perform surgery. So in general, there are two types of navigation systems, and we will have demonstrations of both in the lab. The first is an electromagnetic system, which uses a control unit, an electromagnetic field generator, and specialized sensors. And then you have optical systems. Those are the ones that we are more typically familiar with from placing instrumentation. And that's the one that, you have the infrared tracking camera, and that tracks all your instruments. So those are really the two types if you split them into two. And there's a great paper by Dr. Telfian from a couple of years back that talks about the differences between optical navigation and electromagnetic navigation. And as you can see here, I scratched out the part about the reference array because, as you'll see, there are some electromagnetic systems that do attach to the bone, and there are some optical systems that don't attach to bone. So I think that one is probably not correct at this point, but everything else in here makes sense. The biggest thing is that both improve the learning curve. One of electromagnetic needs more evidence, but I think we have that now. They help with localization. Clearly, both of them help a lot. They decrease operating room staff radiation exposure and really helps with doing surgery. So we had to switch around things a little bit. So we're first going to talk about an optical system, and it's going to be a 2D navigation. So for that, Dr. Abd-El-Barr is going to be in the lab, and good to see you, Mohammed.
Oh, awesome. Thank you so much. And thank you for the organizers for inviting me. So I showed this instrument navigation system at the MIS course, but it's also a system that I use for all my endoscopy systems. So basically, there are these things that go on the regular C-arm and then use the normal infrared tracking. There's no need for any type of CT scan or anything like that. And you can put any instrument and put this array on it, and then it will learn where this thing is there. So today we're going to talk about, when you're talking first for a transforaminal approach, I really feel for some spine surgeons, it's really difficult. You're going to ask a surgeon to make an incision 9 centimeters off midline, something that we're not really used to. And so I think this system really makes getting used to that and knowing where you are and where you're going to be much easier. So hopefully we'll show that today. So what I do here, you can see here, this is the GUI here. This is what's called the bullseye. This ensures that when my instrument is in the field of view, that I'm taking the X-ray, and so I'm not taking a useless X-ray. And then you have different AP and lateral that you can do. So we'll show that as we go along here. So first thing I'm going to do is I'm going to put my instrument in the field of view, and then I'm going to ask for an X-ray here. Okay, that's reasonable. Good. We're having a little bit of glitches, but that's fine. We're going to go for the L45 here. And you can see that there. And then one thing that happens is that sometimes when you take an AP, you need to figure out the cant and so on. So we figured out a way by making that orange line parallel to the white line. When you switch over to an AP, you're actually going to be it's going to be a perfect AP. So let's go to AP now.
So while you're doing that, something that's important. So you see there's nothing attached to the patient, absolutely nothing at all, which is a great thing. It minimizes the number of incisions and the morbidity of placing a pin or anything like that. So it's a great system.
And Rachel, can you come up? So another thing, sometimes when you take an X-ray, you're not centered on the field of view. So I can feel the midline here. So I'm going to ask Rachel to center here. So to the bazooka all the way out and move the whole screen, the whole thing.
And that attachment, does that attach to any C-arm?
It can attach to any C-arm. There's different ones that are made compatible. So now I've asked Rachel to center here, and now I know I'm coming in on the left side, so I'm going to ask Rachel to come in closer to me a little bit. There you go. Good. And I'm going to move off where I'm going to be. Now when that turns blue, let's take an X-ray. Good. So now you can see how crisp that end plate is at L4, L5. It's perfectly centered. We're a little bit towards me because I want to see us going there. So that's really good. Now, if you look on the right screen, we have these angle finders. So if you want a really complex, Dr. Huang, has these, different situations where he's going very steep and so on. So we've made it so that you can go very steep or very shallow, and you actually will know that, and you can see that angle there. So we're going to do something, a little bit easier. We're just going to go 45 degrees. So I'm going to put my initial dilator. I haven't even made an incision at about 45 degrees. And then, as Dr. Kashlan was talking about, you want to see where you are and where you're going to be. So you can see here on the lateral, we're counting about 7 centimeters to Camden's triangle. And then on the AP, it's a little bit less than that. So I'm going to make my incision just a little bit more lateral. I'm going to use the incision that someone else used previously. But you can see here, I can perfectly see where I'm going to be and where I'm not going to be. And for everybody, this is Camden's triangle right here. And the safest area is going to be right here at the mid-pedicle point, and it's going to be on the lateral as close to L5 as possible. So I've taken 2 X-rays, and I've now made where I'm going to make my incision. So we're going to pretend that we made an incision, and then I'm going to take my first dilator. And so, if it's a very tight space, you can put these things on instruments as small as 2 millimeters. For this one, we're just going to kind of plow through. This is a 6 millimeter, sorry, but you can have as little as 2 millimeters. So you can see here, as I'm working, you can see exactly where I am and where I'm going to be. And so I'm just going to use, 45 degrees. And again, if it's a different case and you got to go shallow or you got to go more deep, you can do that. So you can see here, I'm going to go through here. It's a little bit tight because of the cadaver, but there. And the best thing about this is that I can always stop and see where I am. And if I'm not happy or I'm not, totally sure, I can always take an X-ray. So Rachel, why don't you take an X-ray here? And you can see that the tracking is working really well. So we've taken a total of 1 X-ray, and you can see now, you know, if I have a fellow or if I have a resident, I can be much more confident about where they're going to be, right? Because I can see where they're going to be both in the AP and in the lateral. So you can see here, that should be right into Camden's triangle right there. And take an X-ray here. Good. And then I'll just take a hammer. And just for demonstration here, I'm just going to dock a little bit deeper into the disc than normal, just to, you know, hold it tight because this is a cadaver here. But you don't necessarily have to do that. So let's take another X-ray here. Good. And then let's go into lateral. So if you guys are at home counting how many X-rays, I think we're up to 3 X-rays, right? And you can see that I can see at all times where I'm going to be on both the AP and lateral. The best part of this is that this is fluoro-based, so if anything moves, I have a awake patient, the patient wakes up, so whatever, I can just take another X-ray and reset the whole system.
So Mohammed, do you typically use this for your decompressions or your fusions, or just everything that you need endoscopic?
I do it for almost all my cases, so instrumentation, fusions, decompressions, almost everything. So let's take an X-ray here, Rachel. So, you know, this is a big dilator, but you can see that we're right in the spot that we need to be. I think it makes a big difference also when you're training residents and fellows, right? Because if you're only seeing where you are in one dimension, you really don't know where you're going to be and where you are. And so I'm not the greatest surgeon, but I can make it look pretty easy.
And Mohammed, really nice demonstration. Would you mind also showing us, I think you can actually track 2 instruments at the same time, right? Which is really brilliant.
Yeah, so I'll just take this other instrument, and I'll just take 2 of them here. So you can have Star Wars going on. You know, you have different instruments.
It's your favorite.
Going at the same time. It's not instrument-centric, it's fluorocentric, so you know, you can have different things. So when
Can you make some Star Wars sounds?
when I do my pedicle screws, you know, I have 2 people working at the same time. So then let's put just the K-wire down here. And then some of the things that we've been working on is you can actually use the endoscopic working channel. So we've calibrated this as well. So now you can actually know where you are while you're holding the working channel. So that makes it much better as well.
No, that's great, Mohammed. This is impressive stuff. So let me ask this, has this gotten to a point, just a last question before we keep moving on, has this, in your mind, replaced 3D navigation for these endoscopic, for people that use navigation, or not yet?
That's a really good question. So I think the sweet spot for this technology is in the ASC, where you're doing decompressions and 1 or 2 level fusions, right? If I'm doing a T10 to pelvis and so on, I'm probably going to use 3D navigation. You know, I'm at Duke, so I have all the toys I can play with. So if I'm doing a T10 to pelvis, I'm probably using 3D navigation. But for all my endoscopic cases, for all my 1 or 2 level fusions, I'm using it for the pedicle screw placement, for the interbody placement, and where it really shines actually is in the prone lateral as well. You can imagine if you're doing a lateral and you're doing a prone lateral, having the C-arm here gets in your way. So I can move the C-arm totally in a different position and see where I'm going to be and where I am and where I'm going to be.
Love it. No, thank you so much. Great presentation. And if you have any questions, we can take them at the end. So that's a great example of an optical navigation system. This is 2D. So if you can go back to the slide. So these are some examples of 3D systems that are out there. So as you can see here on your left, you could put percutaneous pins in the PSIS and navigate utilizing a navigated jam sheeting needle. You have masks that you could put on the patient, like on the right side there, that's doing a cervical foraminotomy. So you see there are multiple different systems that are utilized for what we call typical spine surgery, or instrumented cases that we could utilize for navigation and kind of rig the instrumentation. So again, navigated jam sheeting, you could navigate the reamers, as you can see here on the right side. So there are many ways of being able to do this. You can navigate, just like what Mohammed was showing, you can navigate the endoscope, you can navigate the endoscope channel. So there's really many ways, and you just have to utilize what equipment you have at your hospital and what works well in your hands. And when I first started utilizing for this, it's stealth and O-arm, I was not confident that it was going to be accurate, and so I took a lot of x-rays even though I was using it, and what you could see here is that it's pretty accurate. It's good enough. So I got to a point that it definitely decreased the number of x-rays that I was taking because I trusted it more. So this here shows the navigated jam-sheeting needle. Here shows the reamers that are navigated with the sure track for this system here. But again, any system has these capabilities. This is an example of Dr. Khan, who you will see here in a little bit, giving a talk using the navigation, the Stryker navigation system, and you could see really shows, this is in an interlaminar approach, showing that you could see exactly where you are. So if you know where your disc herniation is, you can navigate right to where the disc herniation is, and not only will you see the disc with the endoscope, but you can also utilize navigation to make sure you're at the right place, make sure you're past midline, make sure you're above and below the disc space in a way that minimizes the number of shots, and I think is more clear than looking at x-rays, especially in tougher situations where it's a larger patient and x-rays are not good, scoliosis cases like what we saw earlier today, and then in terms of for cervical, which I'll show you here in a second, for counting, because counting is very difficult when you have either in the thoracic spine or in the cervical spine. So this is an example of how the navigation system doesn't get in your way when you're in the OR if you put it in the right place. And this is, again, Dr. Khan doing that. And this is what I was talking about earlier. When you're doing cervical cases, this is a patient who I wasn't planning on using navigation initially, but I couldn't see with the x-ray, even with the AP. And probably it was a problem with our instruments because this patient wasn't that big, but I brought the navigation in. You could put the clamp on the Mayfield when it's a cervical case. And then not only was it helpful for counting, but it was also helpful to figure out my lateral extent of my laminectomy and the contralateral extent of the laminectomy. So this really helped with my learning curve, and I think can help with a lot of people's learning curve as they're going through this process, especially if this equipment is already at your hospital. So could this be done with 2D navigation? Mohammed showed a great talk of that. So you really don't have to have 3D navigation. It could be 2D navigation, and whatever works well in your hands, whatever works in your hospital system could be very helpful for your learning curve. So that's the optical system. So the next thing we want to talk about is the electromagnetic system. And I'm not sure if we're ready in the lab for it yet, but are we? Probably not yet. Okay, so I guess while we're waiting for that, any questions about the optical systems while they're setting everything up? Or any thoughts from the faculty, anybody here, about the utilization of navigation and what cases you navigate?
I'll just say, first of all, navigation is very helpful when you're teaching, training. And then the other thing, as we saw earlier, deformity cases, those kinds of things where it's very challenging to orient the fluoro to get your appropriate views. I really find navigation to be beneficial there. And the third kind of case type I've used it often for is thoracic disc herniation, so you can really have a better idea of where you are centrally, dorsally. You have a better anatomical understanding. Yeah, so I found it beneficial there.
Absolutely. I think for me, the cases that I think it's the most helpful are lumbar transforaminal, especially in larger patients. It gets you into the foramen a lot easier. And then, like I was saying, shown in the cervical case, counting. A lot of times, when we're choosing our entry points, we're choosing them based on standardization, the medial part of the pedicle or the lateral part of the pedicle. And when you have navigation, you really could aim directly at the lesion. Same thing with, going out laterally for a transforaminal approach in the lumbar spine. You're really able to aim, just like what Dr. Wong showed earlier today, if there's an inferiorly migrated fragment, you want this angle. If it's superiorly migrated, you want this angle. And with navigation, you're able to pinpoint where it is and like a sniper, in a way, aim directly at that lesion and know exactly what bone you need to remove to get there.
So, Osama, you want to point out a couple of pros and cons for endoscopic applications that would distinguish the optical versus electromagnetic systems? What are the different features that are making these systems uniquely, useful, or what are things that might be potential hinders or obstacles?
Absolutely. So I think the two issues that I think are differences and make one, at least in your hands, better than the other. So when you have an electromagnetic system, you don't have the line of sight issues like we always have. Again, usually in endoscopic cases, there's not that much stuff in your way, so it's usually not that big a deal. But I think that the biggest deal is for EM, what you're navigating is the tip of the instrument, where usually in optical, you're navigating the back of the instrument, so that gives you some uncertainty that you don't have with an EM system, because the EM system, because it has the wires coming out, you're tracking the tip of the instrument. So I think that's, I'd say, the biggest benefit. And then if you're someone so most of us here do the trans-SAP approach with the Jamshidi, so you can navigate that with optical, but if you use a spinal needle, you can't really use optical because the tip is so flimsy. So that's a situation where an EM-type system would work best in your hands. But that's at least what I thought. Any other thoughts?
One downside of the EM system, the area, the field of where it works is pretty small typically. Okay. So it can be a little finicky to have that field generator in a position so that you can navigate your whole surgery. So it's really only can cover like 2-3 levels or so.
That's a great point. Yeah, especially now with the new navigation systems where you can really get a lot of levels. Again, for endoscopic, it's not that important because most of us are not doing numerous levels, but let's say if you're doing a fusion or doing something at one level and doing an endoscopic decompression multiple levels above, then yeah, that makes a lot of sense that you want the biggest, biggest range of instrumented levels. So, yeah. So how are things going in the lab? Okay. All right, so I'll just...
So you talked a little bit about, so what are the endoscopic procedures where you feel is the biggest need or the biggest benefit for navigation? I mean, you mentioned a little bit of stuff, but, like on a ranking.
Yeah, so number one for me is for targeting for transforaminal lumbar cases. So, for thoracic cases, I definitely see the reason why some people use it, but for me, you only have 1 degree of freedom in a way, because you're going usually for thoracic disc, you're usually going straight and parallel with the disc space, and your starting point is usually right where the curvature of the rib is. So there's really not that much in terms of difference that you're going to do, but for lumbar cases, there's a lot of variability depending on the patient's anatomy, where the disc is. So lumbar, transforaminal, in my hand, honestly, all of them I navigate. So that's number one. Number two is cervical cases that I can't count the levels because of some problem with with visualization with X-rays. And that's very easy to do. The lamina and the cervical spine, Peter showed us, are very shingled. It's very easy to perform surgery, or at least dock at the wrong level and think with X-ray that you're at the correct level. So having the lowest threshold in the world to utilize navigation for cervical cases is, I think, phenomenal, especially that you're not really navigating off of, sometimes you have to do a spinous process clamp, but you really, a lot of times, can navigate off the Mayfield, and it really minimizes the morbidity for a patient. Yeah. But I think it's very helpful if you're in a training facility. It's very helpful if you're learning. It adds time, for sure, no question about it, but I think it's worthwhile at the beginning of the learning curve. And for me, honestly, even as I'm kind of getting towards the end of it, it's still helpful as a check of where I am and targeting. And as you saw from that pilot study, it decreases the number of shots for the OR. It's really, really helpful, at least in my hand. So, awesome. So I think I could maybe just keep going with the robotics, and then we could do...
I want to access the disc with this trajectory.
Oh, there you go. Perfect. What were you saying? Someone was saying something? Was that from the lab? Okay, all right. So yes. Dr. Khan looks like he's ready.
Yes, thank you very much, and thank you for the organizers for having me. We had a wonderful demonstration of the optical system just a little while ago. This I'm going to show off in electromagnetic navigation system and see how that can incorporate for our endoscopic targeting in this particular case. So the workflow for navigation is pretty similar. Regardless of what kind of procedure you're doing, cranial or spine. So the patient comes in, you can have pre-op imaging that you can use for some systems. For this particular electromagnetic system, you need to get X-rays, AP and lateral to register. You have patient mappers that go on AP and lateral that are table mounted. You get a couple of X-rays, you register, and then those patient mappers go away. This is, thank you. This is just an example of one of the mappers that go on. So there's nothing on the skin really for these patient fiducials. This EM navigation system does have a patient tracker that is mounted to the patient, so it's a little different from that other EM systems. However, we only need a single pin to attach to the patient, so it doesn't even need a incision, really. You can go in the spinous process or the iliac crest as long as it's out of the way, but within the field that the EM emitter is generating, that'll be good. So quick point, so for this navigation system, we can have almost all of our instrumentation navigated. We can use the Jamshidi needle. That's what I generally use when I'm targeting for my transforaminal. And I'm going to show you a L4-5 transforaminal approach. But you can also have an 18-gauge needle as well that we can target. And then I'll go through the dilators and the reamers that can also be navigated. So that makes each step pretty seamless, and you don't have to take x-rays at each step to know where you're at. Now, the other part of navigation, of course, is the planning aspect. And we've talked about how navigation can allow you to do fewer passes to get to where you need to go. An example of this is, now if you remember this x-ray, this is from that scoliotic patient we did earlier this morning. It's really challenging to target with fluoro. But if you have navigation, and this is perfect, you can earmark your target before. So if I'm doing a trans-SAP at L4-5, and if you can see my screen down there, thank you. You can have yourself, your assistant, or anyone target the SAP pedicle junction or the arch for a trans-SAP approach. And then it's a matter of using your Jamshidi needle in deciding where your entry point is, and Dr. Abd-El-Barr went through that. It's about a 45-degree. Depending on what you're targeting, we're just going to do a standard transforaminal trans-SAP approach. We don't have to go to ventral or to dorsal. But for example, I can put my needle right exactly where I think I need to go and have my assistant just point to my starting point. And then we have a starting point and a target. And for those of us who have done, for example, brain biopsies, can relate to this. Essentially, you just put the green in the target. Let's see here. And advance. The advantage of the EM navigation is that our sensors, and I'll show you the wire in just a little bit. Our navigation actually tracks the tip of our instrument. Now, for endoscopic cases, there should not be any bend in our instrumentation as we advance it. However, if there is any bend, our navigation, EM navigation system can catch it.
And again, that's different with optical. If you bend the optical instrument, then it's not going to be
correct. So you won't be able to tell, because the optical instrument navigation extrapolates from the position of the optical fiducials. Perfect. And I'm docked, and I know exactly that I'm docked on my target. So the next steps are essentially the same as you would for any trans-SAP approach.
So I mean, this is just, I mean, this is the biggest selling point for navigation for a complicated patient like this. I mean, this took, you know, you have to set it up obviously, but it took a couple of seconds to get to the point that usually we would definitely struggle with, you know.
Thank you. And I'll take the K-wire. It's back here, I think, yeah. The next step is, of course, putting the K-wire in. For this particular system, you can also navigate, like I said before, the actual dilator, which can be just one dilator, so it can be one and done. Thank you. Let me show you this dilator. So this is the actual dilator. It has this attachment in the back that allows the fiber. Yep, let me see here. You want to break it? Thank you. So this is the actual fiber that goes in and tracks, and it has two sensors, one at the tip, one at the base. Perfect. Thank you. Of course, you use the patient tracker to register the instrument. Perfect. You advance it through, following your K-wire, and again, you can track your instrument as it goes in, making sure that it's going in exactly where you want it to go. Perfect. Take out the K-wire. Yeah. There you go. And then you just put in your working channel. Yeah. And you can actually also ream. I won't take too much time, but let me show you the actual reamer, which is also another interesting feature of this particular system, is that you can track your reamer. So if you want to ream through your SAP, you can clip on a tracker, and then you just ream over your dilator, and it will again track the tip of your instrument. So we are taking a lot of X-rays if you're not navigating at this step to make sure that we don't go too medial to the medial pedicle line. Right there, yeah. But you can, for this particular system, just track it as it progresses forward, making sure that you're safe. Perfect. All right, and then when you're done with that, I won't take too much time here because we've done these steps before. But you can then just put in your working channel and you're off to the races with your endoscope. Perfect. Any questions?
Awesome. Thanks for the great demonstration. Again, this is a perfect case to show how much easier it is when you have navigation. Does anybody have any questions for Dr. Khan? Yeah, please.
So, the main reason navigation is intriguing for me is just for the obese patients or the morbidly obese patients, but it seems like if you can't get a good X-ray, essentially the optical and the electromagnetic just aren't going to be as useful since they rely on the X-ray. So is that really all we're left with the O-arm, if I'm understanding it correctly? Is that an accurate understanding?
So getting good X-rays is important. I agree with that, and depending on the system that you're using. Yes, so if X-rays are going to be tough, then yes. If you're doing a 2D system, it may prove challenging, although I think that in most cases, you're still able to get decently good X-rays to be able to navigate off of. Saying that, and we'll see the next navigation system shortly, you can get an O-arm spin or intra-op CT and get 3D imaging for those patients that are bigger who you cannot get good X-rays in, and then those navigation systems would work just fine.
Awesome. All right. Well, thank you so much for that demonstration. We'll have more time for questions at the end. So,
thank you.
Now we're going to shift. So we looked at the benefits of navigation. I think the last case showed that this definitely has a place in endoscopy. But can we add semi-automation to this? And that's where robotics comes in. So these are some slides from Dr. Hasan, who's going to be setting up right now. And we're going to have a couple of videos while they're setting the robot up. So navigation allows us to get from point A to point B. But can we make it where rather than us say where we have to go from get to point A to point B, can we make it a self-driving car? Can we include many different types of information on the path to allow us to take the best and most optimal route to where we want to go? And that's where robotics is and where robotics will take us. So the pros to robotics, as we all know, are accuracy, speed when things are going well, obviously in the OR, reproducibility, and minimally invasive applications. We have multiple papers that show that using robotics helps with doing surgery, especially instrumented cases, and then it adds value to the workflow, to doing the single position laterals and multi-level perc fusions. What are the cons? There is a capital expense, there is a learning curve to this. The fact that now it's not really a robot, it's a cobot, where it's just, in a way just holding our hand to put in screws. But that will change at some point. It will become more of a robot with time. So right now, not many people are using it for decompression. We're really using it mostly for screws and for guiding implant placement. So how can we merge, and these are again Dr. Hasan's slides, how can we merge robotics and endoscopy to make this worthwhile for us and for our patients? And the way that we describe this is, robotics is like having the self-driving car, and then endoscopy is like having a sniper or having a motorcycle. And what Dr. Hasan says is, if you merge these two together and you have a self-driving motorcycle, that's what the area between robotics and endoscopy gives us. So image guidance helps. with getting us to the next step, which is robotic targeting, and he's going to show us that in the lab. And then after you do the robotic targeting for a lot of the bony work, you can have endoscopic visualization. And with that, you have the most semi-automated, reproducible result to get yourself into the foramen. So this is a video here to kind of showcase a case that Dr. Hasan did. And as you guys, whenever you all are ready in the lab, we'll skip any videos that are left. So just let us know when you're ready, please. So this is an example of targeting and utilizing the robot arm and the drill to perform a lot of the bony work. You know, a lot of these patients that have facet hypertrophy, when you're doing an endoscopic fusion, you want to try to get, to get things to be more just faster. So after you drill a bunch of, you take a bunch of tracks through the bone, then you can bring your endoscope in and you're really not having to drill much bone. You're just having to drill the shelf of bone left from the robotic drilling. And this is just putting in the cage. This is in a, as you can see, in a cadaver lab that Saqib did. So he took these skills from a lab and took it to the next step, which is doing it in his bed. And again, we saw all this stuff yesterday in the demonstration. So this is getting the end plate prep and then getting a bunch of disc out and then getting the end plates ready. So and again, we saw this yesterday. This is just an example of doing this in a, with the robot. And then you put in the implant. So I'll skip over the next thing here. So you can pre-plan screws, pre-plan your implants, and pre-plan with endoscopy your decompression as well. So this is a patient who came to see Saqib, who decided to proceed with a prone lateral at 4.5 and an endoscopic TLIF at 5.1. It was a very large patient, so doing this endoscopically at 5.1 was more useful than doing it with a tube in his hands. So here is an example of doing a robotic bony removal in the OR, and that's what he's going to show us in the lab once he's all set up. So you can have multiple tracks through the bone that are pre-planned, and you just take those tracks with the burr and then go from there. So. And then after you do that, again, this is just like the video that we showed in the cadaver lab. You could, after you drill a lot of the bone, the bulk of the bone with the robot, then you can come in with the endoscope and things are already drilled out for you. So it saves a lot of time and helps with this being automated. So he's identifying the traversing route. So this is just the TLIF steps. And just let us know, obviously, when you all are ready in the lab, because I think that'll be better.
Can you guys hear me?
Yes.
Okay, perfect.
Okay, awesome. All right, so I'm going to leave the steps of doing an endoscopic TLIF. This is the result, great result. Prone lateral 4.5, endoscopic TLIF, and you can see the cage is coming in from way lateral, which is typical for the approach they took, the transforaminal TLIF. And these are the steps for the endoscopic TLIF, so I'll leave them up. Actually, no, they're up. Yeah, go ahead, Saqib. Yep.
Thank you, Osama. So, Ben, if you could please just kind of put on the robotic screen, we can show the trajectories. So I want to just show you guys that I did 2 trajectories here. And, some people might argue that you just need 1 trajectory if you're going to do a true transcambon cage. But typically, if I'm going to do an endoscopic fusion, I want to put the bigger cage in. And for you to put a bigger cage in, you need to take bone out. There's just no way you can fit that 10 millimeter, 12 millimeter cage through a foramen that's just going to cause a pretty bad injury to the exiting nerve root. So what I did in this planning is that, this is currently off-label use, which is going to change very soon, but off-label use, I have to use a screw trajectory. So what I did is, if you can look at the screen here, I planned a screw to where I want the bone to be removed here. So you can see that there. And let me just see here. So what we're going to do first is we're going to, we've planned all our stuff. We're all set up. We have the 2 fiducial markers inside the PSIS. What we're going to do next is we're going to use the robot and get to our trajectory for the bony removal. So I'm going to do that first. You can see it's a different trajectory because we're going to land more on the facet. And the reason why we're doing that is because this is pretty much percutaneous, you don't want to be near the exiting nerve root. You don't want to be near the traversing nerve root. You just want to help remove some of that bone so that when you're going to put a cage or a larger retractor in, you're going to have more room. So I already made my cut. So the nice thing about the robot, the Globus robot, is that it's not just automated, automated way of putting screws in, but you can also use it for navigation as well. So you can see that I have my drill here, and I can kind of look at where I am. I already made my skin incision. So first thing I'm going to do is I'm going to put this down. And you can see, get the knife again. Okay, put that there. So
when you're doing the Saqib, so do you have the same issues with skiving as you have with screws sometimes, and how do you prevent that?
Well, the skiving it's different because you're putting a screw and you can have really hypertrophic bone and skive off the end. But in this trajectory, I'm actually just planning to be on the side of the facet. So I kind of want to just stay more medial than anything if this wants to go through. Okay, let's see that.
And Saqib, aren't you digging into the end plate there if you go too deep?
Excuse me?
Aren't you digging into the end plate if you go too deep?
No, yeah, I won't be going deep. This is a superficial drill. Sorry I didn't mention that. My goal here is just to go superficial to create some of this channel here. And then if the robotic arm, let's say I plan my trajectory and it's too lateral, what I could just do is I can actually deselect the screw, and I could actually hold the ring and move it a little bit like that. And you could even do this freehand. So let's say I don't like my trajectory. Let's say I'm going to put this in, and I don't like to be right there. So you can see I'm drilling bone right there, right? Can you guys all see the robot screen?
Yeah, absolutely. Yeah, we see it well.
And then let's say, oh, I don't like that. I want to drill more bone, and I don't want to be limited by the arm. I can just move the arm out of the way and then just use the navigation function. Because essentially, the robot isn't anything without navigation, but it's kind of like that auto drive function, right? Let's see if we see here. Okay, right there. So you can see now I'm on the facet joint. I can feel, I have palpation. I'm feeling the facet joint. I can actually drill some of the bone here.
And in real life, how many how many trajectories do you choose, or do you do this with freehand?
Well, I prefer, if I could get it in one trajectory, it's better, but because then you have two incisions. But generally, it just really depends on how much bone you're removing, how comfortable you feel drilling blindly like that. And like I said, that's why it's really important that if you're going to drill, and we do this a lot when we're doing navigated cases, we just put our Midas burr in and we kind of just drill the facet to help facilitate fusion. So we're going to now go back to our original trajectory. Let's go back to this one, L3, right? And now, so this is the part, so we did our blind drilling. Now when I check what I did, and I can finish the drilling under visualization. So let's gonna put this guy in there. So we're gonna go here. Tool's not visible. So I'm right there on the bone, okay? I'm gonna take this off. We're gonna take the robotic arm off again, deselect that. Okay, with the end effector off. That'll make it a little bit easier. So I have my trajectory. I'm gonna move the robot out of the way. Now really, you might ask, like, what's the point of doing all the robot stuff? The reason is because once you do your drilling, you can then go back to your original cage placement, and then you can, actually I'm gonna use let me use the retractor, tubular retractor. Yeah, we're gonna put this in there. Okay. Okay, let's get the endoscope in. So this is the trans-SAP endoscope. It's a little bit bigger transforaminal scope. This allows us to work, and we can see, get the irrigation on again. Fluid. Okay, so get the RF probe. get the focus better on this thing. Okay, we all learned about the soft tissue dissection.
And the trans-SAP scope, just for who don't know, it's larger diameter than the regular transforaminal. Is that correct?
Yes, it allows you to put bigger instruments in, and if you're putting a bigger cage in, you want to have bigger instruments. So we went from the robotic targeting to endoscopic visualization. So I should be seeing bone right now, and I am seeing bone. And the reason why I think the endoscope is important is because, you know, if you just do everything blindly, you can eventually, you know, you might be good for a while, but eventually you're going to have a problem if something's just off with the anatomy, or if the robot didn't register, or something just changed. So what I'm going to do is, now you can see this is some of the bone I drilled already. Now I'm going to take my drill. Is it clear for you guys in there?
Yeah, no, I think that's great now, Saqib, and I think this is exactly what we want to see, just the visualization of the drilled bone. And I think the rest of this we could do in the lab. What do you think?
Can you just put that on for a second to show a little bit, and then we'll,
Yeah, absolutely. Go ahead. Yeah.
and I'll be done pretty shortly. So we can just drill the bone, and essentially you're drilling this bone with a big drill. Eventually, as I pass through this, it's going to kind of open this corridor a little bit, and the whole point of this is not just put a cage in, you know, and we'll just, for the interest of time, we'll take this part out, and then let's say we drilled all this bone out. I would drill this bone, I would look for a traversing nerve root, I'd be happy with where I am. I can actually then place a needle into the disc space and then dilate from there if I'm happy, or then I can go back to the robot and I can then, you know, plan my trajectory out again. So I'll just do this. I'll go to inner body, or actually inner body, right? Go to inner body. Yep. Put the side effector back on.
And Saqib, can you also use a navigation during the endoscopic part?
Yes. So I mean, like I said, the robot is essentially it's like when you're driving a car, right? If you put on auto drive is not going to work well unless you have some kind of navigation. So they're kind of two technologies that are married together. You can't really have robotics without navigation. So I think that's the real crucial part of this, that you can use the navigation, you can use the robotic aspect of it. Really, for me, the robotic aspect would be, let's say I want to have a perfect cage placement. I would do my endoscopic drilling, like you saw, then I would go to my cage trajectory, and I would then put my cage in, and this would tell me, okay, if you guys look at the robot screen, my cage has to go there. So in the interest of time, what I've done is I've removed some of this bone, which you can't see, but imagine some of that superior articular process and some of the IAP would have been removed. So if I needed to put in a bigger cage, like a 10-millimeter cage, it would be more than possible. I won't go and do that part. I won't do the discectomy because we've all seen that yesterday. I think everybody wants to get to the lab unless anyone has any more questions.
No, thank you so much, Saqib. So if you can switch back to the slides, there's just a couple, 2, 3 more slides. So talks about the first, the steps that Saqib does for his endoscopic T-lift. So they're listed here. And then the next step in terms of the future is going to be, you know, merging endoscopy robotics and navigation already there with potentially virtual and augmented reality. We talked about the, you know, doing percutaneous T-lifts could be potentially dangerous, but if you're mapping the nerve roots, which, you know, Mohammed's doing in his lab, you could potentially pick the approach to Camden's triangle based on the area, the side that has the bigger opening into Camden's triangle. So with all that stuff together, virtual reality, augmented reality, robotics, and endoscopy going together, you could potentially think that, you know, potentially in the future have some type of spine Da Vinci that could come up in the future. So the take-home points from this, navigation, is it friend or foe? I would say friend. Robotics, is it friend or foe? I'd say friend. And future uses are going to just continue to increase. So being involved in the discussion now is going to be important for you to continue to be involved in the discussion as these things become more and more useful. So thank you so much.